Dr. Milhoan, welcome to Why Should I Trust You?
Thank you so much. A pleasure to be here.
So, you're the newly appointed chair of the ACIP committee, which of course helps set America's vaccine policy. And given that, and given the fact that you're a physician, we just thought it might be, might be useful for you to talk about your philosophy towards vaccines. I mean, do you like them? Like, which are your favorite? Which ones don't you like so much?
What an appropriate podcast for me beyond why should I trust you? Since there are many in the press that are trying to convince people not to trust me, and I would say that trusting an individual is dangerous. I think trusting the actions of the individual are much more appropriate. I think that we live in a polarity where you are not allowed to be in the middle. You're either to be this or that. You're either to be pro or anti, for or against. And so I think one of the reasons they chose me first to be on the committee and then to be given the chairmanship was the measuredness I bring to a discussion. When I was doing my PhD, it was very clear to me that in my own mind, I had a confirmation bias. I had a hypothesis, and I really needed that hypothesis um, to be right. And if it weren't right, I could have wasted years and years and years. But if you're going to have character and have integrity, then you have to examine your confirmation bias and decide, why am I doing this? So I come to this. I don't have a favorite vaccine. I don't have a vaccine um, that I have any personal, emotional, necessarily opinions about. I look at what the data are, and I'm not afraid to say, wow, that's a really good vaccine, or that's a really bad vaccine. I look at medicines the same way. There are medicines. I try to use the least amount of things I do to make somebody better. The less I do, the less I have a chance of doing harm to somebody. And so I think that we've talked a lot about the efficacy of vaccines, but I think what has been neglected is really looking deeply at what the risks are. And everything I do, especially if we inject something that bypasses first pass um, elimination and detoxification, it's a bigger deal than if we take something orally, usually. So there's a risk for everything we do medically, from a simple antibiotic to heart surgery. There are risks, and people act differently. So I think this is uh, what I desire to bring is sort of pulling back the curtain and telling people, what do we know and what don't we know? So when I give informed consent, I can be honest.
You're right that when we talk about vaccines like they're ice cream flavors, what's your favorite? It can seem a little off. So let me just ask you even more specifically, like you take something like MMR and you take something like the polio vaccine. You deal with children in your practice. What do you think about those two vaccines when you just framed it as efficacy versus risk? Help put it through that framework even for those two vaccines.
Let's take with the polio, because it's probably one of the ones that's most known, most talked about. Jonas Salk, his work. There's a Salk Institute in San Diego, the university I did my PhD at. So in my lifetime, I watched us go that if you can take an oral, if something goes through the infectious process, goes through your gut, a vaccine works better if it goes through your gut. So there was an oral polio vaccine, and then there was an injected polio vaccine. And in my lifetime, what was found is that there was we were giving people polio with the oral vaccine, and so we switched to, while I was still a resident in pediatrics, we switched to first to giving the injected dead vaccine without a live polio virus, and then we went to oral doses after that. Now that's even changed a little bit more, but that was evaluating risk and saying what was right, what was wrong. I think also as you look at polio, we need to not be afraid to consider that we are in a different time now than we were then. Our sanitation is different. Our risk of disease is different, and so that those all play into the evaluation of whether this is worthwhile of taking a risk for a vaccine or not. We have to take into account that are we enjoying herd immunity right now? That it may look like it's better not to get a vaccine than to get a vaccine, but if we take away all of the herd immunity, does that switch? Does that teeter totter switch in a different direction? That's how I would look at both oral polio or polio vaccine and the MMR vaccine. Um, the MMR vaccine, and you guys have probably seen this data, is that often that the incidence of disease is going down even before the vaccine had been started. When we look at the risk and we talk about the risk of let's say, measles, many of those risks of getting measles without having a vaccine um, was in the 1960s. We take care of children much differently now. Our ability to have pediatric hospitals, children's hospitals, pediatric ICUs, how we look at the whole gamut of how we can treat measles is different. So that's something that comes into play. Are we looking at real today data with our population? And are you traveling? Are people traveling to you? What I see in Africa is much different. I see diseases in Africa that I don't see here. I've never seen a case of congenital rubella affecting a child in my career. Now, it may happen, but I haven't seen it. In Africa, I saw 3 in a day.
But
So
Dr. Milhoan, you wouldn't be in favor of getting rid of the MMR vaccine. You wouldn't be in favor because as from the data that exists out there currently, measles is a highly infectious disease. Pre-vaccine, it was killing hundreds of children a year,
1960.
hospitalizing tens of thousands of people. But that was before the vaccine, and so the vaccine is you're right, and I don't think anyone disputes the fact that things like sanitation and the way we live our lives absolutely played an effect. But I think it's also fair to say that the vaccine played an enormous effect in the reducing of this disease burden in children almost entirely. So I think, as people look at ACIP, I know there's a lot of people out there who think that are MMR and polio safe, in terms of this schedule, because it feels like those two vaccines in particular have proven to really stem the disease in its tracks.
I think that proven might be a little bit harsh, a little bit strong word for what it's done because of the pre-vaccine decrease in incidence of disease. But I understand what you're saying. If you look at the current outbreak of measles that's happening in the U.S. right now, I believe 75 to 80% in those numbers are unvaccinated. Um, what we're going to have is a real world experience of when unvaccinated people get measles. What is the new incidence of hospitalization? What's the incidence of death? Um, so I think to go back to a bigger question about what ACIP is doing, remember, we're just an advisory panel. We can't make any declarations. We can tell you what we believe the evidence shows, and we try to do that as transparently and honestly as the data supports and present data. But it's been very important to us, the members of the committee, is that what we are doing is returning individual autonomy to the first order, not public health, but individual autonomy to the first order. And so what you'll see is a change in wording and a change in words that we use, but it's much more of who's the patient and the doctor, and they know each other, and they should be making the decisions on what the risks are of disease, what the risks are of vaccines, which is different for each person, what the family history is, and then make a decision from there, as opposed to what was sort of more of a heavy-handed authoritarian thought of the vaccine schedule that led to mandates that if you didn't have this set of vaccines exactly how they were prescribed, then you didn't get into school. So just my own life, what I have to do is people come to me often because so the press would like to label me as an anti-vaxxer, which I'm not, but it's a label. You're either pro-vax or anti-vax, so they've labeled me. So then some people seek me out because I've been labeled an anti-vaxxer. One was a 17-year-old girl who was 2 months away from her 18th birthday, which means that she wouldn't necessarily need all the catch-up vaccines. But she wasn't going to be allowed to graduate in a month unless she was fully vaccinated to the childhood schedule. Um, so it made a difference 2 months, and then 1 month after, it wasn't as big of a deal. That's really sort of nonsensical medical thing, just that we have this rule and you have to abide by this rule. If I saw 17 and um, 17 years old in 10 months, I wouldn't think, oh my gosh, we've got to get this childhood schedule finished in her, or we're in big trouble. I wouldn't look at it like that. But what has happened in the past, and this is different where we're an outlier to much of the rest of the world, is that often the ACIP recommendations became mandates because of funding and other issues that were involved, because the funding of vaccines for kids was often tied to the recommendations of not only ACIP, but the CDC. We make a recommendation, the CDC has to basically canonize it.
I just want to ask you about your philosophy around individual autonomy. And I'm wondering if you are looking at the vaccine schedule for our children sort of in two camps. Like, there's one camp that's diseases that if I don't vaccinate and I get that disease or my child gets that disease, they're not going to spread it to somebody else, most likely. There's other diseases that are highly contagious. So an individual's autonomy, an individual choice not to be vaccinated suddenly means that my immune compromised child is at threat. You very well could pass measles, easily pass measles to my child. So where do you see the line for individual autonomy versus you are infringing on my child's safety by the choice you're making? It doesn't just affect you, it affects my child.
Yeah, and so I would say I agree. There are two different things at play here. We don't take one over the other. But let me just put it. Let's just flip that the other way around. What if the child gets a measles vaccine to protect your immunocompromised child and gets a negative consequence from that? Wasn't that your child causing that child to be harmed?
Right.
So
But
you see that.
but it's predicated on you feel there's a greater risk than what established science says about something like the measles vaccine. You feel the risk is high enough that the children, it's a very acceptable, even perhaps laudable decision to not vaccinate your child because of the risk of an adverse effect from measles, and that outweighs the risk of your child spreading it to another child or a child who's, God forbid, compromised.
No, I think this is hard when you're trying to do autonomy versus public health. I think these are hard
Yeah.
decisions to make. Right? This is why it's nuanced. This is why I don't like the different camps that come up with. This is really hard. I think that a couple of things. I wouldn't use established science. Um, we've gotten in trouble with that.
But that's interesting. Someone who's chairing the ACIP committee, you don't like that. I mean,
I don't like
I'm not
established
criticizing you.
science.
I'm curious what you're probably going to be getting a lot of reports and a lot of files and a lot of data that's been established, things that we've looked at and pursued and
So that's not
investigated.
science.
Okay,
So
that's not
that's not
science.
necessarily science. Science is what I observe. And is there a confirmation bias in what is established science? So this is what I'm saying is if you're looking for right now there's a major pertussis outbreak in Texas, and 100% of the people who got pertussis were vaccinated. What we know
Sure.
is a lot of times for respiratory viruses that inactivated injectable viruses aren't very good at blocking transmission. It can decrease the burden of the disease, which is what you'd want in something like whooping cough. But it's much more complicated than no risk to get the vaccine, all risk for someone who's immunocompromised. It's more complicated that when I, as a physician, have an obligation to do no harm. right? So if I give something as a physician, I recommend to my patient, I personally assume some responsibility. And the Hippocratic Oath talks about basically doing no harm. So especially when I'm using something that is for prevention, that has a higher standard to clear when I look at risks.
Uh, you said something interesting to me that, you said science is what I observe. And as a doctor and a scientist, in a sense, I agree that observation is the starting point of science very often. It's not necessarily, the conclusion. Science is systematic testing of observations, and then we do trials, and then we have data, and then we see if I can reproduce it, and then we have verification. Now, I just want you to go back to that point, because as the chair of the ACIP committee, can you tell us that you're approaching your work there not on your observations, but on science?
Well, that's what I'm saying is I'm looking at the observable science. And what I'm saying is that there is a emotion that it is, when people use the word proven, this is scientifically proven. It's a contradiction to the word science when you're looking at observations. And when we look at something that's statistically significant, you're still saying it's at a 95, let's say it's at a 95% confidence interval. What does that tell you? Well, 5% you're wrong. So I think it's not that I'm being anti-science. What I'm saying is let's be honest about the words.
Mm-hmm.
So I don't like to use the word safety. Safety is not a scientific word. Safety is an emotional response to a risk. Does someone feel safe? Right? That's a feeling depending on what the risk is. So when I have discussions with people, and I understand this, is that people have different emotions depending on what their perceived risk is, or what risk they're looking at. So I will talk to somebody and say, well, why wouldn't you get MMR vaccine if you could avoid measles? Then I have someone else who will say, and says, well, why would I get a vaccine if it has a risk associated with my child developing encephalitis? So people can look at what they choose as the risk is what they're often will say, well, I'm more concerned about something being injected into my body than getting a disease. Other people are more concerned about getting the disease.
Yeah. So are you saying you're describing safety as something that's subjective?
Yeah.
So I think that a lot of people who study safety and do the work, don't view it as subjective. Obviously,
I think they use the word risk.
Risk. So you would prefer us to use the word risk as opposed to safety?
Yes.
Okay. Do you think that the vaccines are appropriately studied for safety?
No, they haven't been. They've been mostly studied for efficacy.
And what about all of the monitoring that happens and the
It's
risk
very
of
poor. It's very poor.
So you
In
think
fact,
it's just
I'm just explaining to you what I have observed when I ask and I look, and what you see, what recently happened that came out from the FDA is there was a very large death signal in children.
Have we
That
seen the
wasn't picked
data on?
up.
Have you? That's a
Yeah.
great point. Have you seen the data behind that?
Yes.
You
Yes,
have.
I'm also a pediatric cardiologist, so I'm very acutely aware of myocarditis
But
in
the data
children.
that hasn't been made public, you've
Yes.
seen that,
Mhm.
This is
and you're
just to
convinced.
be
So,
clear,
so
Dr. Milhoan, just for a little
Yeah.
context.
sure.
We're talking about when Vinay Prasad wrote that memo talking specifically about the COVID vaccine causing deaths in children. And you're saying you have seen that data
Yeah,
because it has
exactly.
not been produced publicly.
So let me explain. What a lot of the safety signals have been looking at is ICD-9, ICD-10 codes. Okay. Those come off the end of the chart. And probably the person who's done the most work on this was Tracy Beth Hogue. And she came and actually presented. She's presented in our work group. She's part of the work group, and she's presented at the ACIP meeting, the most recent one. And when there were at least 10 cases when you did a chart review, not just an ICD review, that it was clear that it was the vaccine that had caused this. What you also see is if you look at the Nordic nations that have been studying this very, very closely, they had such a signal for myocarditis. that they said, we're not going to give this, especially Moderna, to anyone under 40. So they saw a signal, and we saw signals early. And so what happened is that safety net. So with the vaccine safety data link and VAERS, those are sort of early warning systems, especially when you roll out a new vaccine on a new platform.
So a couple of things on that. I mean, I think that we have a lot of data that people are looking at, and I think that there's a sense that myocarditis can happen, and we all have agreed that the risk of myocarditis after COVID vaccine is there for a certain subset, but it's a much lower rate than people who have a, say, natural infection. We're talking like 1 to 10x. Sorry, go ahead.
If you look at the Nordic data that looked at 23 million vaccinated children, the lowest rate of myocarditis was in the unvaccinated. As you increase the number of vaccines, Moderna was worse than Pfizer. This was the JAMA Cardiology article. 23 million children.
Yeah.
And the lowest, what they used as their baseline rate was the unvaccinated, because that was the lowest rate. And so they based it off the unvaccinated. And the more vaccines you got, the higher your risk was for myocarditis.
Right. But the Nordic data did indeed say that there was an increased risk of myocarditis in unvaccinated, in the unvaccinated population.
Not over the vaccinated population.
Right, but doesn't that just establish that what we know, which is there is a very rare risk of myocarditis for vaccinated?
I wouldn't say 1 in 2,500 is rare for someone who has a very, very, very low risk of complications from COVID.
Do you agree that it's much higher if you have just a natural infection?
No,
that the risk of myocarditis.
The data don't support that.
So much of okay, I mean, I guess that's just a point of disagreement, because I think much of the literature does say that.
I think that is said without data.
No.
And you have to look at what they consider unvaccinated. Remember, for a long time when we were doing this, if you didn't have every booster, you were considered unvaccinated. If you only had one, you were considered unvaccinated. You weren't considered partially vaccinated. The definition of being vaccinated was having all of the recommended shots. If you look at the methods, that was much of what was going on. So it's not clean data when people say it's only those risks were higher in the
well, I think what you're talking about is that we have a lot of people in a hybrid situation, that you have a natural infection and you've had the vaccine, so it makes it more difficult to understand. But let's just move on from that and just agree to disagree a little bit, that the risk of myocarditis is indeed higher if you have a natural infection, and that it's mild if you do get it in the vaccine. And obviously there are some subsets of the population that it was shown to be.
If you look at the
higher.
Lancet article, they showed that people who had enhancement on the MRI with late gadolinium enhancement, that after 90 days, even when everything else was normal, 50% of those patients still had LGE positive MRIs.
Yeah.
Which are I think risk associated with arrhythmias and sudden cardiac death. So I think the data out there is when I go to the world meetings and we talk about the MRIs, I will tell you that the pediatric cardiologists that are looking at the MRIs in a subset of children that were very low risk for this disease is alarming. And when you listen to Paul Offit talk about, he told Dr. Fauci that this is a very low risk patient group and they don't need to be given the vaccine. And Fauci said that we're going to do the same for everyone.
All right,
That's concerning.
Let's move on a little bit and just let's go back to some. I have a philosophical question for you. You've talked about freedom of choice and how important that is for parents when they're deciding about when to get a vaccine. And, as a doctor, and I think you could also probably vouch for this, that doctors already individualize care, but we rely on clear evidence-based recommendations as a foundation, as a baseline. And is this idea about freedom of choice, is it really about expanding choice, or is it something more? Are we taking a step back from making our choices based on evidence-based recommendations? And you're in a position of power now. So we know that this guidance is important and falling on a lot of ears. I mean, when guidance is softened, fewer people, if they're listening to your guidance right now, I think a lot of people and fewer people are going to take the vaccine. How is that an increased freedom? And why is it not just reduced, protection from vaccines?
Well, I guess that's one way to look at it. I think that the concerns that are coming forward of what happens when you stimulate an immune system over and over again, concerns for increasing incidences of non-disease related hyperallergic responses in children is concerning. Asthma, eczema, other things have been concerned. So this is a risk benefit that I believe needs to be discussed with everything. But there's always going to be a tension between what is supposedly good for all and what is good for the individual. There is going to be that tension between doctor-patient relationship and public health. So you can run through lots of different scenarios in terms of you got the vaccine, the disease was prevalent, you didn't get it. No side effects from the vaccine, great. 100% great for you. Let's say you got a vaccine for something that you weren't going to be exposed to in your life and you had a negative response to that. That was not beneficial to you at all. So what we're trying to do is have the discussion over that there is a nuance here in terms of autonomy and public health. And when you look at the ethics of doing things to people, autonomy is very important as we look at malfeasance, autonomy, all the sort of standard pillars of ethics. Are we allowing people to have body autonomy? So I just feel like this is part of the discussion.
I guess, do you hope that less people get vaccinated?
No, that's not my hope. My hope is that it's more of an informed decision.
But if you're talking about numbers and people,
I don't have a desire for less people to get vaccinated. I want my desire is to have as low of a side effect profile as we can that has the maximum efficacy in preventing disease or preventing horrible outcomes. That's my desire. I don't have this. I'm looking for a vaccine-free world. I don't have that as. I want to have an honest discussion. Right now, when I try to have a discussion with data, what often I have is I immediately get name called. They don't bring data back to me. I get name called. I'm just trying to have a discussion of what is out there and what I see.
Yeah, we don't want a name call, so we are in favor of those discussions.
I'm not saying you guys are.
Yeah.
We can't.
This is why I love this platform, to have this discussion. Whatever I believe, it should be challenged. It should be challenged.
Dr. Milhoan, let's talk a little bit about, so Secretary Kennedy recently, along with the Trump administration, made the move to overhaul the schedule. And this had happened, just a few, months after ACIP had made the recommendation to change the Hep B dose. So my question was how did that land with you? Did it bother you that ACIP wasn't consulted before? I mean, this was the most dramatic change to the vaccine schedule in generations. What went through your mind? Did you wish ACIP had been consulted first?
I believe ACIP had been consulted to get all those things approved. And then what the discussion was is, and I don't know if you guys had a chance to read the executive summary by Koldorf and Dr. Hogue. What they were looking at is we're an outlier for the rest of the world, and our childhood wellness isn't better than the rest of the world. It's just not. Our infant mortality isn't better than the Western world. So they looked at those vaccine schedules and they said, what do they all have in common? What do we see as best practices, and how do they do them? So really they used those to bring together. But I didn't have a lot. I didn't feel offended that they didn't consult ACIP. Because they weren't necessarily adding something new, and they didn't take anything away financially or doctor-patient relationship-wise.
Well, so
Just like
here's
with the
why I
hepatitis B.
ask.
They're saying like we're taking these things away. We haven't taken any things away. We've made sure everyone has access to any vaccine doctor, patient agree they should have.
But you've
So
changed recommendations.
What?
You've changed the recommendations.
Yeah, because we were concerned about mandates, and mandates have really harmed and increased hesitancy.
So let me ask about that because I think so. I want to get a couple of things in here. This is good. This is good stuff. I just want to make sure we're untangling some of the different threads.
Yeah.
So
Yeah.
back to what Secretary Kennedy did. I think the question I have, Dr. Milhoan, is we have ACIP for a reason, right? It's a committee where, you've got various types of people working with experts, themselves pediatricians and practitioners. You have these meetings where, they're open to the public for people to sort of see a process take place and try to understand and make sense of decisions. And I think, and I'm speaking on behalf of many people, and I want you to sort of empathize with this for 1 second, which is, can you see how a process whereby the head of HHS, along with the president, comes out and says, we are no longer recommending a whole slew of vaccines because we want to be more like other countries, and here you go. And there's no real workflow that's presented. There's no evidence and data that's presented. It's just like, this is what we've decided. And I imagine if you're ACIP and your entire job is to work through a process so that you can make the case to the American people that you're recommending something that you truly think is in their best interest. Can you see why some people are head scratching in this moment?
Yeah, I understand what you're saying. I think to say that there wasn't data presented, I think that's ignoring the executive summary that was put out by Koldorf and Hogue. I think that they also looked at much more risk-based, like let's say rotavirus, which is a very popular one. Rotavirus is an interesting vaccine because it got pulled very shortly after, and they knew beforehand that it was a risk, and they brought up before ACIP that it was a risk, and they said still went ahead with it, and then within a year they had to pull it because of the risk that they saw, but they in a sense ignored, said it's probably okay.
Are you talking about when you say
Shield.
the risk, are you talking about like way back in the day?
Intussusception.
So like decades ago. Okay.
Yeah, 1994. So when you look at that, in Africa, the death from dehydration secondary to rotavirus is dramatic. Hundreds of thousands of kids. The number for rotavirus deaths in the US, if you look at all takers, is 1 to 3 million kids have a death from rotavirus. So because
It's
of that,
like, sorry, I just want to make sure I understand. So like, I think, sorry to interrupt. I think that number, it's like 1 out of 3 million may seem, but I think it was like pre-vaccine, it was like 20 to 50 deaths a year from rotavirus.
Yeah,
in America?
In America. And like something like 50,000 hospitalizations a year.
Yeah. So, and also remember that how we do dehydration and over time, our care of children and our care of sick children is dramatically different in the US than others. So that is one that was risk-based, and other countries have done that same thing and made it basically optional for doctors. Now, if you're going to be traveling internationally and these are all things that should be in the discussion of what are risks and benefits about everything. Do I put everybody on prophylaxis who travels internationally? No, because I really respect the gut biome and I don't want to kill off a whole bunch of very helpful bacteria that live in our gut. So I think that this is not something that came out new. It's been a discussion. And so when even in our ACIP meetings, we were having the same discussions over what's the best way to put it? I live on an island where there's a lot of tourism, a lot of hotels. And as a hotel gets old, everybody knows the hotel is getting old. And sometimes you can just destroy the hotel. Or sometimes you just say, well, it's okay. It's old, but it's okay. What I like is I don't necessarily want to destroy the hotel, but I also am not afraid to say that the hotel needs to be renovated with new times and new data. And so I look at things like, this is a renovation, and we'll see. We'll see. But remember, I don't know if you guys saw the lawsuit that was brought by a number of different medical organizations against HHS and the secretary. One of the things they said is that we don't have enough time to give proper informed consent.
Hmm.
If you ask us to do this, we can't do it. But they tell us they give informed consent.
I think
Right? So this
Dr.
is a big
Milhoan,
issue. In their
yeah.
lawsuit, they're confessing they don't have enough time in a doctor-patient relationship to give informed consent.
So you're bringing up something that I think is so important, because I'll tell you as a mother, if someone tells me that they don't have enough time to sort of talk to me about vaccines, like that would make me upset. I agree with you on that. And I've heard that, I think I told you this, that we have a lot of MAHA folks on our show, and they tell us about their experiences where they were supportive of vaccines until they had a really negative experience at the doctor with one. But the thing that really is persuasive to me, Dr. Milhoan, is that there are people who are increasingly losing trust in vaccines in this country. We're seeing that in our work. We're seeing that in data.
Concern as well.
Right. What I am not persuaded by is at ACIP, at the ACIP meetings, like if that was what you guys led with, which is like, look, people are really not trusting this stuff. And if they're not trusting it, we got to either work with them in this informed consent world and figure out what works for them based on their risk profile. But what it felt like the meeting was turning into was talking about the safety profiles of these vaccines without showing a lot of evidence for whether or not the safety was in question, to the point where I think Cody Meissner and even Robert Malone at one point towards the end said, we're making this recommendation not because we think on Hep B, because we think the vaccine is inherently unsafe, but because we don't necessarily think that the birth dose is necessary in the first 24 hours. We can talk about the 2-month thing later. I have some questions about that. But do you see what I'm saying? Like, I actually know public health officials and doctors and experts who are like willing to talk about flexibility on the schedule if the goal is that if you allow flexibility on certain vaccines, you actually then like enhance uptake in other ones that are really crucial, like MMR and polio and things like that. And I guess like react to that. Like, could there have been, and can there be, a really like an evidence-based argument on trust as opposed to a lack of evidence-based argument on safety for certain ones of these? Which is not to say I don't want to talk about safety. We absolutely should.
But I would address the issue as I was in the work group that talked about hepatitis B and birth dose. There were plenty of data presented. Going back to your issue of do we bring up the hesitancy, this is one of the reasons why I wanted to join ACIP, because I'm really concerned about the loss of trust in physicians. And it's not just vaccines. It goes across the whole board. Do they trust any medicine we're giving them? The concern that there is money to be made in medicine and doctors are somehow all bought off and paid for by pharma, that they're not looking out the best interest, but they're looking out for their pocketbooks, is really quite a prevalent view. And this is really hurting all aspects of medicine, just not vaccine medicine. So we brought up one of the things we brought up in the first one. I remember I've only been to, I was in September and I was in December, but I haven't.
You're the new guy.
Yeah. So, but in September, we talked about, what the healthcare provider uptake of the COVID vaccine when it was fully recommended by CDC, 10%. Healthcare providers, 10%. You know why that was? Is because when the mandate went away, people stopped taking it. You know what the uptake is for flu? 80%. You know why that largely is in the medical community? Is because if you don't get the flu vaccine, you get an exemption, you have to wear a mask for the entire flu season. So people just
isn't flu uptake a lot lower in this country now?
You're saying among healthcare
workers.
I see what you're saying, Dr. Kirk. So Dr. Milhoan.
So what I actually brought up at the ACIP meeting, and other people did as well, is that if we don't bring back trust in the CDC recommendations, that we truly do talk about the risks and benefits, we talk about the safety profiles, if you will, of these things, we become irrelevant when the CDC recommends something and only 10% of the healthcare providers who should know best. Right? Who should know what the real risks are, how concerned they are about a disease. I will tell you, if I was an animal catcher, I'd have a rabies vaccine.
Dr. Milhoan, though, you're talking about people not wanting to trust it, and then how does that like play out when you give out a recommendation. But right now, like pediatricians across the country are literally ignoring the advice that you're putting out. The lawsuit that you mentioned, one of the defendants in there is the American Academy of Pediatrics as like an entirety. How are you building trust if that's how you're being received?
Yeah, well, how am I building trust in patients? So I don't have just one agenda, right? I haven't come to be, I look at the totality of what the difficulties are, right? AMA makes recommendations. You know how many doctors are signed up to be in the AMA? About 10 to 15% of the population. Most of those are medical students because you get a free JAMA article, journal in medical school. So is that speaking for doctors? Not necessarily. And so what we're, yeah, this is a real problem, right? Because I'm not, my whole life as a pediatrician isn't about just vaccines. My whole life as a pediatric cardiologist isn't just about myocarditis, but I see this bleed, and it changed when things were mandated and people couldn't go to school and they couldn't do this and they couldn't do this to get a vaccine that has really been a large failure. I mean, Cody Meisner even said, he goes, this is the dishonesty regarding the COVID vaccine is monumental. He said that at ACIP meeting, right? Because we have to be honest with it, right? When was the last time you needed to get 4 boosters a year if you were over 65 for a vaccine? We see IgG subclass switches to IgG4, which is it's recognizing it as really an allergen and is ignoring it. So this is a real problem.
But you don't even see its efficacy in the early stages of COVID when the vaccine just came out in terms of lowering, in
Yes.
terms of lowering hospitalization rates, lowering death rate. Like, you're right. As far as transmission went, like once those other waves started coming on, I think you'll get very little argument from a lot of folks that like whether or not it was preventing transmission. I think you're absolutely right that in my estimation, public health oversold whether or not it could prevent disease. But or prevent transmission. But do you also think that it did not reduce disease burden?
I think it helped in the first, well, Alpha was out. I think as soon as Delta came out, it was largely ineffective. But yeah, absolutely. I saw that clinically. Remember, I treated a whole bunch of COVID patients on this island in their homes because the hospitals were rejecting seeing them.
Let me just stick with trust for a moment.
Sure.
According to the Wall Street Journal, during the December meeting, you were picked up on a mic that was open, talking to Dr. Cody Meisner, and you said, I want to talk to some of the higher ups. You went on to say a little bit more of a discussion of where we want to go with this and what do we think the pressing issues are and what are those things that aren't so pressing. And then obviously the quote that I think a lot of people heard, which was, that you were sort of comparing yourself and the committee to puppets on a string as opposed to really being an independent advisory panel. So I just straight up, what were you referring to?
I was referring to what it's like to be a committee member when there are lots of different pressures and threats coming in. We have a whole email thread of all the threats we get as ACIPs. Okay. So what we're trying to be is independent. But if you were at the ACIP meeting, how much really good science was given by the organizations that came up? Were they questioning science? There were a lot of ad hominem attacks. How many children were going to die because of our this or stuff like that?
So you weren't referring to
I was referring
the puppet
to
master is not Robert F. Kennedy.
No, I haven't.
It's not HHS.
I haven't had anyone say, Kirk, this is what we want you to make sure is voted on. I have not had that happen. This next meeting that we have coming up, the subjects we're finishing up the details about what we're going to be talking about, and we're in work groups even today. I have one in a half an hour that we will that we don't have any. I haven't felt any pressure. I haven't felt like, Kirk, you need to do this.
So nobody's.
In fact, if anything, I felt like from the White House they wanted me because they felt I was going to be not one extreme or the other.
Got it. So there's no meeting where someone says, hey, take this on next, we want you to
No.
look at this now.
Now we can be asked. We're an advisory panel, so the CDC can ask us, HHS can ask us. If there's a new product that comes out, we're going to be asked to look at it. But we have a lot. The charter gives us a large breadth to, if we're seeing signals that have been ignored, then we can go back and look at that. I mean, Brenda, you brought up something about the CDC. Remember initially they said how effective it was? That if you get the
95%.
vaccine, 100%, then 95%, then 90%, then 85%, then 75%. Remember that.
Yeah, but that effective at what? I think we should clarify. What do you mean by that?
Well, let's clarify that, because you know what? When people get a vaccine, when they get a vaccine for tetanus, do they expect to get tetanus? No.
No,
So,
but what the 95% was preventing clinical disease. It wasn't preventing an
Well, to
infection.
be
It wasn't
fair-
They were
preventing
saying-
transmission.
That's not
Dr.
what they were
Mark,
saying.
I am
So-
with Kirk on this one. I think
this is
that
not
Yeah,
what they were
was,
saying.
That
I mean,
may
you
be,
and I have disagreed on this too, which is
yeah,
that
but
So let
I
me
think-
bring up another point.
Wait,
bring
let
up
me
another point.
say one thing, Dr. Kirk. I'm with you on this one. I think that what was happening at the study level and at the clinical level was not being communicated that way to the public, Mark. It was
but
being
we can talk about
sold-
communication.
It was being
but-
sold as a vaccine that could prevent COVID. It could prevent transmission and it could prevent COVID. That's how it
Well,
was
we
being
can go
sold.
back.
In the
but
early
any-
studies, if you look at the early studies, and what hospitals were doing is, if you were vaccinated, when you came in with a COVID-like illness, they did not test you for COVID because you had been vaccinated. And
let's
and the CDC also changed, it had to change its definition of vaccines from preventing to ameliorating symptoms or hospitalization.
Yeah, I mean, this
Okay.
sounds like a lot of the nuance that you're asking for, but
Absolutely.
let's
And
talk
honesty
about
the data.
You mentioned the charter and what ACIP is supposed to be doing. I want to ask you how the new ACIP is working. Specifically, are you still using sort of the best practices that have been set in place for ACIP, for decades? For example, like the grade framework, which is, how we assess the quality of evidence. Are you still using the evidence to recommendation framework? One of the criticisms that we're hearing is that it's not necessarily being applied. Can you commit that you are still using those best practices of ACIP, or are you revamping the entire way it's being used?
Those best practices were used for the last 5 years, and how did they do to protect the society?
Kirk, I
How do
would
you
say
think?
say right now we have a measles outbreak in this country,
Yeah.
and there's real fear that infectious
Exactly.
disease is going to come back.
That's a hesitancy issue, not an ACIP issue, right? That is not an ACIP issue. That's a hesitancy issue. What you're referring to is, how do we evaluate evidence? If you look at grade, if you look at evidence to treat, they are looking primarily at efficacy. They are not looking at safety signals. So we had a major failure in following safety signals with COVID, even though grade and ETR. So what we are looking at now is, how do we incorporate aspects of the ideas of and the concepts of grade? How do we evaluate data, and but at the same time have within that framework that we're not looking just at evidence to treat, but we're looking at safety signals as well, which is not really set up in grade and evidence to treat. So are we bringing scientific rigor to this? Absolutely. I would say we're probably bringing in an increased level to examine safety, because if you're not specifically setting up studies to look for safety, you're going to miss it. And you have to, especially vaccines for children, it's not a 3-day study or a 5-day study or a 7-day study like they did with newborn doses of hepatitis. You have to watch them for a while.
Are you saying just so I'm clear, you're saying that the old ACIP wasn't studying safety adequately, and you were trying to reinvigorate safety as a priority, and do you believe that the current post-marketing and surveillance systems and the VAERS and the FDA databases and the CDC databases, none of those are able to do safety in the way you want, and you have a new solution on safety?
I don't have a new solution. We're working to figure out why it broke. right? And so when we bring up VAERS, people say, well, you can't use VAERS. Well, it's CDC's invention. So we actually have to look, and that's why one of the people on the ACIP is a safety expert. He looks at all aspects of safety. So this is, I think families demand this. There's an assumption that it's safe, but have we looked at it and have we studied it? And we
Yeah.
need to have rigor in doing that, because my obligation as a physician, and it should be as a public health official as well, that we do no harm.
Yeah, I think you've mentioned that, and I maybe the audience doesn't know, but you've done a lot of mission work. I think you're one have talked about the impact of delaying care, and I think you even
Yeah.
talked about how you were finding children in various states of cardiac diseases that were so late, and how delaying or withholding care led to this irreversible harm. And I think that, and I wonder, have you reflected on your words today and your position today, that a lot of what you're saying is influencing parents to delay or refuse vaccination because you're really raising this question of safety? And how do you weigh this like possibility that you're going to have unintended harm? You know, I believe that you want to do good for patients and make sure that everybody gets the vaccines they need, but there could be some unintended harm. Do you recognize that,
Absolutely.
especially to this population that you're trying to protect?
Yeah, absolutely. And Mark, do you recognize there could be unintended harm if we give it? That's what I'm trying to have the discussion. There's possible for unintended harm both ways. There's possible for unintended harm if you don't get it, and there's possible for unintended harm if you get it. And let's just have them both as a discussion and not be afraid to talk about it, because they're
Do you
not
think
100%
they're equal, though?
safe.
I guess for parents, it's so hard to understand.
It
You're hearing
depends
a
on which
doctor.
vaccine. Mark, it depends on which vaccine, which person's in front of you, and what their risks are. It's not the same. It's nuanced. And to make a one size fits all, which is what has happened, right? If you look at RSV, what was RSV? We used to treat RSV with monoclonals, and it was for the ones who are at most risk. So the ones who are at most risk, right? I'm taking care of a kid who has RSV and has a heart defect, right? They were 9 months old. They didn't get any RSV protection at all. I've had them in the ICU for 3 months. Right? Am I aware of these things? Absolutely. But do we need to does it need to be mandated for you to go to kindergarten that these kids have every one of these vaccines that are recommended? That should be individually based. That is what I do as a doctor.
So you don't think the medical exceptions for those school mandates, you don't think that's working? You don't think there's enough?
Oh, Californians are not allowed.
There's no
There's
medical
only
exception.
a couple of states, right? Dr. Milhoan, it's California, New York. Like there's a couple of states. But let me ask
There are
you
other exemptions.
Let me ask you, just following up from Mark on that, which is, it seems to me that you're weighing the risk of disease equally with the risk of adverse event. Does that sound accurate?
No.
Okay.
No.
So with that,
It's not true, because each vaccine is different, right?
so let's just take measles, for instance. I think you talked about MMR and polio up top. We're doing a return to theme here as we wrap up. So let's go back. You know, you've got a measles outbreak right now. Can you look into the camera and say the best prevention against measles is the vaccine?
I think it's very helpful. Is it 100%? No. But is it very helpful?
Pretty damn close.
Do you have data for that?
Yeah, I mean, like we do. Like, for example, like if you have a natural measles infection, like the risk of like terrible pneumonia is like 6 per 100, or death is like, 1 to 3 per 1,000. But if you talk about the adverse events from the measles vaccine,
1 to 3 per 1,000 in the US for measles?
in developed countries.
1 to 3 current data?
For natural, if you have a natural measles
not current
complication.
That's
That's in the New England Journal of Medicine, but that's okay. We can double check it. But
well,
that is.
Let's double check it, Kirk. Let's make sure we're right on that. I agree with you.
Because the point is that for the adverse events are not even in the order of per 100 or per thousands. They're per million. Per anaphylaxis is per million doses. Seizures is per like 3,000 to 4,000 doses. Like the complications from the platelet complications that you might get or the encephalitis. They're not even in the same order of magnitude. So yes, as physicians, as doctors, we all want to like put these like risks and benefits in the appropriate context. And
Yeah.
I'm wondering, do you see that? Do you feel like you have a little bit of bias towards like putting them on equal playing field?
I don't put them on equal playing field. So I started out talking about bias, right? I was honest about that. I talked about bias, right? So let's be honest what all the biases are here. It's okay, right? I'm really concerned about my role as a doctor and informing somebody. And now I have the AAP saying we don't have enough time to inform people, but they were telling us before that everybody got informed consent. When I told people when I was giving children, when I was a general pediatrician, I was giving children oral polio. I talked about people with immune deficiency in the house. It's not smart to give a live virus when you have people with immune deficiency in the house. So we needed to do things differently and separate things right, and I wouldn't change the baby's diaper. Right? We did those things. So all I'm saying is this: do we have real data that we can say this is your risk of encephalitis if today you get measles in the U.S., right? And this is your risk of doing that. I think we should be able to make a very, very strong, compelling argument from data to convince people to get things, whether that's
Even
a
with
vaccine or anything
something
else.
like as contagious as measles, like an
Yeah,
R
this
naught
is probably
12 or
there's very
whatever.
few things that are as contagious as measles, right?
And you think
Um,
that can still be like an informed consent situation where mandates aren't necessary to go to public school? You don't need a measles shot to go to public school because
they don't have, most countries around have very limited things that are mandated, and they have high uptake of vaccines.
Right. But they're obviously, this, you travel the globe. I mean,
Yeah.
there's a million reasons why other countries have high uptake and America has lots of systemic problems, issues, deficiencies. And I just want to clarify, every state allows a child to be exempted from the mandates to go to school for a medical reason. Some
No,
states
that's not
that
true. I just
that's
had a phone call yesterday from a person in California whose child was dramatically affected. They did genetic testing, they had the Merthyr gene in the other two kids. For the whole time they've had doctors saying these other two kids should not get the MMR. They should not. They should not. They put it through because you can no longer, as doctors, you can no longer write exemptions for children. That has to go through a medical board, and they refused
right.
exemptions even though
oh,
doctors were
you,
over. I
you're
talked to this
saying
person yesterday.
You're saying
you're s-
anecdotally, you're finding people, the system's not working for them. They're making the case and they're getting rebuffed, they're getting rejected. That's what I
on
think that's what
medical
you're saying, right?
exemptions.
But it sounds like your legacy, as if you could craft it for your time at ACIP, would be to break from the past and start to really examine in the data, hearing observationally from doctors across the country, what is the safety signal you feel from your suspicion, your hunch, although you said at the beginning you could be wrong, but your hunch is there's safety issues that have not been surfaced, that we're maybe looking at tip of an iceberg. Would you put it in that
I'm not
stark of
sure tip of the
terms?
iceberg is the thing
How would you put it? Yeah.
I wouldn't put it as tip of the iceberg. I think what I would like to be able to do is give people medical freedom, and I would like to, and I would, and I think there are things that I would compel them that I think this is a good thing. And I would say, well, in terms of your whole risk and everything else, you're not going to Africa, so I probably wouldn't give you yellow fever. You're not a dog handler, so I'm not going to give you rabies. But this is what I'm concerned about, and this is these are what the benefits that I see from this vaccine. This is what you can expect from it. And this is the risk of taking it. What I'd like my legacy to be is not that we destroyed the vaccine schedule, but I would like it to be that, wow, he had a compassion for children and families and wanted to do everything we could to keep them healthy. And I have those in a balance. And there are some things that it'll go like this, and other times it'll go like this. But I don't like the medicine. I feel medicine is going into a algorithmic um, place that leaves the outliers vulnerable.
Dr. Milhoan, as we start to wrap, I just want to reflect one viewpoint, which is that we've talked about distrust in vaccines and how there's hesitancy, and we need to figure out a way to empower the American people with good information to be able to make good choices in their lives, empower doctors to be able to,
Yeah.
Recommend the right choices. There's also a lot of people who do trust vaccines in the country. And there's people who really rely on them to keep their kids safe. And you're absolutely right. They are weighing that cost benefit analysis. I have made the decision to vaccinate my children based on my decision to trust data and trust that they will benefit more than they will be harmed. I guess my question is, can you assure people listening that ACIP is going to be making recommendations for everybody, not just the people who are not trusting of something and may require a different process, quite honestly, but it's also going to protect people who rely on these tools. I mean, 80% of this country, including 66% of MAGA supporters, say that they would be very upset if the childhood vaccine schedule were to be altered, or that even that they support the public school requirements for them. So can you help me just to feel assured as a mom, and other moms feel assured that you guys aren't trying to take away our vaccines?
Well, for one, we haven't taken any of them away. If you want your vaccine, you can have it. If you want to use the old schedule, you can use it. We haven't taken anything away. It will still be paid by all the major insurance companies. Vaccines for Children program, the CHIP program, Medicaid program, all those things. We haven't taken any of that away, right? If you would like it and you and your doctor think it's important, that's still available to you. Going back to the other things, what we're trying to do is we're trying to update the vaccine safety sheets and sort of like the handouts. I saw a pediatric practice recently. They had a QR code that patients could scan. They would give them before the appointment, and here's the vaccine safety sheets for all the vaccines your child is scheduled to get on this date. We'd like you to go over them, and if you have any questions. It was a very nice, novel way of getting information out so people could have time to really go out and then bring questions to the. I think those are beautiful things to do. That's what I would like to do. Is I would just like to have really true, informed consent for an intervention. That's all I'm asking for. Right. Like I said, I don't have a dog in this fight. It's like, oh, I really want this, or I really want this. That's not how I'm coming to that. Is that some people are going to think, and this is why I go against the word safety. So if I were to say it's a 1 in 10,000 chance, some people say, okay, I'll go with that. That's safe to me. Other people go, is it a 1 in a million chance? It's not. It's worse. It's not as good as a 1 in a million. Then I'm not going to go for that. Right. Those are numbers I'd like to give. And then what is the reality of those things? I had a professor when I was in fellowship, and he said, Kirk, when you're the person, it's either 0 or 100% for you. Right. It doesn't matter if it's 99% that you're not going to get it. If you're the 1%, it was 100% for you. And
if those diseases start making a comeback, say people really listen to the recommendation that you don't need to get rotavirus and you don't need to get this and you don't need to get that, and people really start, and I've been hearing anecdotally, Dr. Milhoan, of people calling their pediatrician's offices saying, it sounds like I don't need to get this. If diseases start to make a comeback, would ACIP change its recommendation?
Oh, I think that's absolutely true, right? We're not God here, right? People are giving us power we don't have. We can advise that we're saying that we didn't change anything, and we're letting doctor-patient relationship back on board, right? And we're encouraging doctors to take that place and look at the nuance of the patient in front of them. So if we look at something and we go, wow, okay, we did this, and look what happened. This is not good. Right? Everyone got upset because we recommended that you not give MMR and varicella together at the 1-year dose. You could give it at the 5-year dose, but not at the 1-year dose. We didn't take them off, but 85% of the people already weren't giving them together, and because the risk was twice as high for febrile seizures if you gave them together, and that was because they had to increase they had to increase the quantity of varicella vaccine in the MMRV to 7 times its regular dose. 7 times its regular dose to get it effective, because it was fighting against all those the other 3 in the compound. So we said, give it separate. You give it separately on the same day, and there was no increased risk. But people had said, you're removing. No, we didn't remove anything.
Yeah, Dr. Milhoan, you said, we're not God. And you're a man of faith,
Yeah,
correct? Yeah. And you've asked God before what to do. I mean, I've read
all the
some of your
time.
work, and you've said, God, what do you want me to do? And that's how you ended up being a pastor. I think that's how you started some of your mission work.
How I got to be on ACIP.
How you got to be on ACIP. And you trust God. If you were wrong, okay, if you're wrong, and you said you could be wrong, and your current stance has caused some harm, how are you going to recognize that? What in your life has positioned you to recognize that? Is there somebody in your life that has permission to tell you that? Like, how are you going to know if you're not on the right path, especially when you're so, visible now, I guess? Like, take a moment to think about how you're going
I
to.
don't have to take a moment to think about that. I'm wrong about things all the time. I can tell you what I hate to be wrong. So if I'm wrong, I want to be right as soon as I can. Adam Grant talked about that in his book, Think Again. I'm not afraid to think again. I'm not afraid to revisit data. I like the work of Malcolm Gladwell. He looks at things differently. I like the work of the book Freakonomics. I like to look at things. Am I looking at this clearly? I came on here telling you that I'm concerned that I even had a bias when I was a PhD student, right? So, and you know what? And my higher authority for me is I stand before God, and if I harm children by action or inaction, both of those are critical to me. There's a quote by Charles Dickens. It says, I love these little ones, and it is no small thing when those who are so fresh from God love us. These families and these children, by designee of their families, are trusting me. And so I want to make sure that what I'm doing for them is what is best for them. And I take that very, very seriously. I recently got contacted by someone on the web, and they said, wow, you have a horrible online profile. We're going to give you a D- for favorability. Right? And between $18,000 and $22,000, we can clean up your Google profile. I said, how do you do that? Oh, well, we just move things up on the Google page and makes you look better. We'll get people to write nice articles about you, and we'll move you up and do that. I'll tell you what I make as ACIP. When I'm there in the CDC, I make $250 a day. I'll do that 3 times. It'll be about $1,500. So what I'm getting from ACIP is $1,500 a year. A negative profile on a career that I love, to be a doctor, and an offer to spend $18,000 to bring back my credibility for something I'm getting paid $1,500 a year for. And my son bought me bulletproof clothing for Christmas.
That is not okay.
That's the reality of my life.
Dr. Milhoan, I want you to know that that is not okay. We have spoken with doctors who've received death threats from public health, from people such as yourself. I just want you to know that none of us ever, no matter how much we disagree on things, want to live in a country where our medical professionals are getting death threats.
And I don't, and this is why I welcome being on here, right? Because I love what your statement of your, why should I trust you? It's a good point, right? Trust but verify.
Yeah.
So I don't feel this way from you. This is the kind of discussion I think we should have all the time.
Yeah.
Right?
And I also have to say that your career of traveling the globe and helping children get access to medical care is so moving and so profound Like in another universe, we'd love to have you back just to talk about that and the lessons you've learned, because it is, if people could hear that, I think they would. I don't think you have to pay the 18K to do whatever to your profile online. We thank you for that. It's a really moving thing that you've been doing.
Well, I'd love to talk about that, because what my desire is for healthy children around the world, right? And so I'm willing to look at everything. I'm willing to think again about my own thoughts, my own preconceived notions. I think what's very important is we need to make sure we don't parrot. So in medical school and in residency and as an attending, often what you would hear is a third-year medical student tell you everything that their team is going to do for this patient, and you realize they didn't know any of that. They just parroted what they heard. And I think it's very important in science that we don't parrot, that we actually go back and look at first sources. Because we can often hear someone give us a conclusion after they've read the abstract. But have you gone back to primary sources and asked the question? Because when I ask questions as a PhD pharmacologist, have we studied this? Have we studied its pharmacokinetics? Do we know when it's out of the body? I'm surprised that I have no primary data. When I look at contamination, I have no primary data. And so this is why I'm advocating so much that we have been missing looking at the risks and what is the perceived safety of these interventions, because I've asked basic pharmacological questions on pharmacokinetics and there are no answers. So this is where my concern is that how do I help children with all of my heart and do as little harm as possible?
Dr. Milhoan, I want to thank you so much for joining us. I know we lose you in a couple minutes. I ask, one request from me as a mom is at your next ACIP meeting, you hold space for people, of course, who are hesitant about vaccines. You hold space for conversations about its safety profile. And I also ask that you hold space for those moms who are really worried about infectious disease and are really worried about them making a comeback should uptake of these vaccines go crashing down, to hold space for all of that, because I think that is what I am entrusting in my government to, not make decisions for me, but also not hurt me and look out for me in some way. So I just ask you hold space for all those types of voices. Will you do that for me?
I already am.
I want to thank you for joining us on Why Should I Trust You, Dr. Milhoan. Thank you so much for coming on air.
All right. Thank you, guys. I really appreciate it.
Thank you.
That is our podcast for today. I am Brenda Adhikari. He is Tom Johnson. She is Dr. Maggie Bartlett. He is Dr. Mark. Please send us questions and comments to questions@whyshoulditrustyou.net. That was Dr. Kirk Milhoan, chair of ACIP and a pediatric cardiologist. And we will see you right back here next week.